Hello and welcome to Insight, the show by TVC22. I am your host, Thomas Stockting. Today we're looking into a very rare and particular story that's surely going to catch the attention and the hearts of everyone in our local community. I'm going to be speaking with Dr. Alexandra Ahmet, who is an endocrinologist from the Children's Hospital of Eastern Ontario, locally known as CHEO, where for well over a decade she has followed the case of one particular local resident. Sacha has type 1 diabetes, but after comfortably living with her condition for almost 14 years, developed an allergy to her insulin, the thing that was keeping her alive. So to dive into this bizarre, rare and uplifting in the end story, I'd like to welcome Dr. Alexandra Ahmet. Dr. Ahmet, thank you so much for taking the time to speak to us today. How are you?
I'm good, thank you. Thank you for having me.
Perfect, thank you. I think before we start, just in layman's terms and quickly for those telespectators who are a little bit like me, were a little bit ignorant on what diabetes was in total, could you take us what type 1 diabetes actually is, just quickly through it in layman's terms for people like myself?
Sure. So type 1 diabetes is actually a fairly common condition in children and youth. So we see about 1 in 400 children will have type 1 diabetes. And it's a condition where you don't make enough insulin. So insulin is the hormone that we use to take sugar from our blood and put it into the cells. And then in the cells, it's used for energy. And in type 1 diabetes, it's an autoimmune condition, which means that the body recognizes our pancreas, the organ that makes insulin, as being foreign. And it will make antibodies, which are normally made to clear bacteria or infection. It makes antibodies to the cells that produce insulin in the pancreas and eventually destroys those cells. And then children are left without making insulin, and it's life-threatening. But fortunately, with modern day medicine, we're able to replace the insulin that's missing after diagnosis. And so that's kind of the basics of it. I don't know if you have any specific questions about it.
No, I think that covers the basics of it to give us an idea, absolutely, where the body has detected this as a foreign cell, as something to attack, and we lead to the point where you cannot produce the insulin. And we're going to get into exactly what that means to the body in a second, but in very few and rare cases, people can actually develop an allergy to the insulin that you give yourself to replace it, am I correct in saying? Which is exactly what happened to Sacha, except Sacha's case is even rarer and more specific, and we'll dive into that in a little bit. But in Sacha's case, what causes this reaction? I mean, considering the issue occurred when she was about 16, 17, and you diagnosed her yourself when she was merely 2 or 3 years old. So how come it took so long for her body to develop this allergy to the insulin she was injecting into her arm?
Yeah, so it's not very well understood. The type of allergy that Sacha has is very different from the more common form of allergy, and that other common form of allergy occurs sometimes. It takes several kind of exposures to the body or to the system before the allergy starts to happen. But this type of allergy, the one that we saw in Sacha, is localized. So it happens just in the fatty tissue under the skin, and it leads to inflammation. So kind of cells that are causing pain and swelling and redness. But even with modern medicine, we don't understand why that happens. There's very, very few people across the world who have this same type of allergy as Sacha has. And so we don't really know why does it happen in Sacha now after many, many years of having diabetes. One thing that we do know, though, is that there likely was something a little bit different with the way that her body was responding to insulin all the way along. Because in children, what can occur when we give insulin in the same spot frequently is we get kind of lumps of fat in those regions. But with Sacha, she was losing fat in the regions where we were giving insulin. And that's much less common than the gaining fat in those regions, but something that we see. but there has been an association. So when we look at the few cases where they've developed the same type of allergy as Sacha, they've also had a history of losing fat in the areas for the insulin, which makes me wonder, is this a process that, it started a long time ago and maybe just got worse over time until it actually started becoming these very painful and red nodules? But to answer your first question, I have no idea why it took so many years for it to happen, but that's also the way things were described in the other cases that have been reported across the world.
Yeah, super interesting that despite the fact that modern medicine has come so far in the last few decades, that there are still so many unknowns out there for us. I mean, as you say there, in terms of you have no idea, because it's so difficult to find, how did you go about diagnosing Sacha? Because, correct me if I'm wrong, I do believe on the research that I did, it was about 3% of all diabetic cases develop an allergy to insulin at some point. So it's very rare. Did your thoughts immediately jump to an insulin allergy?
Yeah, so firstly, the percentage with an insulin allergy is significantly higher than the percentage with this type of allergy. So this would be just a few cases across the world. But for sure, when she came in and said to me, when I'm giving my injections now, it's very painful and I'm getting red hot lumps. So what we did that day was we gave insulin in the clinic and we saw it happen before our eyes. And we assumed that it was likely what we call an IgE mediated reaction. So that's the most common allergy you think about. You hear people talking about hives or getting anaphylaxis where they have trouble breathing. That's the typical allergy that we see. So for that, treatment would be with an antihistamine to start. So what we did was we started with an antihistamine. It didn't work. We tried different types of insulin because each type of insulin has different additives. And when someone is allergic to insulin, in the large majority of cases, they're allergies to the additives and not to insulin itself. But it turned out that for Sacha, her allergy was to the insulin itself. And then we kind of went from there. But yes, when she first showed it to me, it was pretty clearly an allergy, but what type of allergy it was not clear. And that took a lot of time and a lot of tests before we kind of got there with the help of our allergists and our dermatologists.
And you were saying earlier off camera with me, you've worked at CHEO for over 15 years in your specialised role. Have you ever seen anyone like Sacha who develops an allergy later on, and then on top of that, it's an allergy, or as you say, maybe she had it this whole time and it's been worsening, but gets to the point where none of these alternative methods of treatment that are commonly used in these cases are working?
So I'll take it one step further. So I've never seen this. So I presented her at a national endocrine conference, and no one in Canada had seen it. So I took it to the head of the International Society for Pediatric and Adolescent Diabetes, and he had never seen it, and neither had his colleagues. So we're not talking, in my career, I've never seen it. We're talking across Canada. It's not been seen, and even within the world, there are very few cases of this. So it's extremely, extremely rare.
And in terms of what the worst case scenario is would have been for Sacha without an alternative method of treatment, we've heard the phrase ketoacidosis thrown around. What does this mean, and what's the repercussions to the body if insulin cannot be given as a supplement?
Yeah, so unfortunately, without insulin, people with type 1 diabetes will not survive. As I mentioned at the beginning, insulin is required to take sugar into the cells for energy. And so basically, when that's not happening, our body will react or respond to try to produce energy by breaking down fats. But when it does that, it produces ketones, which people might have heard of because of the ketogenic diet. But in this case, these ketone levels are much, much higher. And those ketones are very dangerous. I usually tell patients that it's almost like kind of pouring acid inside of your body. They are acidic, and that can lead to diabetic ketoacidosis, or DKA, which is a critical illness which can be associated when severe with swelling in the brain and ultimately death. Now, the good thing is that diabetic ketoacidosis is treatable, and it's preventable in most people who are able to use insulin injections, and it's treatable by giving intravenous insulin and intravenous fluids gradually, as long as people present to hospital early enough. And we usually prevent them from coming to hospital by kind of coaching them through how to manage their insulin from home. But for Sacha, the challenge was that she was giving her insulin, but it wasn't being absorbed. And that's what led her to have to come into hospital and be admitted for a prolonged period of time so that we could administer intravenous insulin, because that was bypassing the place where she was reacting. So basically without this, the next alternative, so there are two other alternatives. One would have been to stay in hospital forever and have IV insulin given, because IV insulin cannot be given at home because of the risks associated with that and the kind of the care that's needed. So there's very close kind of monitoring by a nurse if you are getting IV insulin. And the other option that we looked at after looking at kind of all the other therapies, and if you're interested in that, we can talk about other therapies we looked at. It might be a bit much, but is an islet cell transplant. So with an islet cell transplant, there are islet cells. So those are the cells within the pancreas which produce the insulin, and they can be transplanted. But it's a pretty new therapy. In order to allow your body to accept those cells, you need to take very kind of strong medications, types of medication, like anti-rejection medications, similar to what you might take if you had cancer, for example. And so there are fairly significant side effects to those. And unfortunately, the islet cell transplants don't last very long. So by 5 years out, and these numbers aren't exact, precise, but somewhere around 90% of people who have had an islet cell transplant are needing to administer subcutaneous insulin, which was not an option for Sacha. I'm hopeful that over time, and there's a lot of research looking at islet cell transplant and looking at protecting those cells, like some are looking at encapsulating them, so putting them in kind of a little membrane before they go in so the body can't destroy them. And so I'm hoping that over time that becomes a good option for Sacha, but right now it really isn't, because she's not like other people who may have what might be called brittle diabetes, where a transplant will give them a little bit of insulin production, but they still need to give some on their own. Sacha was unable to do that because of her reactions.
Yeah, it just goes to show how unique and how rare Sacha's case was. For you, Dr. Ahmet, this is where Sacha was one of your first patients. She was one of the first people you diagnosed at CHEO over a decade ago now. How did it feel for you as a professional, as a medical professional, seeing someone you've known for so long in so much pain and rapidly running out of options, as you say, because you're ticking them all off, you're going down the list, you're doing your due diligence and trying everything, and nothing's working. How did that make you feel as a medical professional, as someone who's known her for so long?
Yes, so I'd have to say it was very hard watching Sacha be in pain and not to have options. It occupied a huge chunk of my time trying to find options for her, because I knew that it was really important for her life and well-being for us to find her an option. She's such a trooper, such a great kid, and very positive person, as is her mom. So I think that really helped them. But as a medical professional, it was tough, and it was really hard, because I looked to my colleagues, and my colleagues thankfully are very, very helpful, and we work together to try to find a solution. But it took a while to find that solution because it was such a rare thing. Yeah.
And the good news is, though, that somehow, needle in the haystack, you did manage to find a solution. Yes. Now, like you mentioned earlier about how you took it to your colleagues in Ottawa, you took your colleagues in Ontario, then you went countrywide, and no one had seen this. So, my understanding, you went global. And you managed to find just a few cases that sort of kind of not even directly and perfectly, but sort of matched up a little bit to what was happening with Sacha. So talk us through the process. How did you finally manage to find a treatment that might work for her?
Yeah. So it was actually really interesting, because when this first started happening, one of our diabetes educators had said, that she had been at a conference once several years ago and had seen a system, an insulin delivery system that bypassed that subcutaneous, that fatty layer, and went directly into the intraperitoneal area, which is the area within the abdominal cavity to deliver insulin. And so that happened actually relatively early on. And it's not something that I had heard of or that my other doctor colleagues had heard of, but this diabetes educator is a very experienced diabetes nurse, and she mentioned it. So at that time, I looked into it, and I contacted the company that was producing it, and they said, yes, we were making this. No, it's not available in Canada. And so we tabled it because it wasn't going to be readily available. And in order to have any medical device come into the country, you need to prove that you've already exhausted all other options. So we kind of did that, and we went through and we worked on the other options. And there was a case report. So when we're in medicine, when we have something rare, we often will go to the medical literature. So in the medical literature, not only has research studies, but it also has case reports. And case reports are kind of a formal way of writing up an interesting or different patient case with a description of how that case presented and how it was managed. And those are published in the medical literature in order to help other clinicians to solve cases if they run into something else that's similar but rare. And so one of the trainees that I was working with was looking at the medical literature and found a case where they were using, again, this intraperitoneal system that we had already looked into. So that kind of gave us support from the initial idea that this might work, but it wasn't kind of an immediate, yes, we know this is a potential option, to we can now use it. And that's where the real work started, because there were a lot of kind of roadblocks to getting the system to Canada, both approval and funding, and then training on this system. Took quite a while because of the regulation through Health Canada for devices.
Yeah, I mean, like you touched on it there, it was such a complicated process to get it through, considering it didn't have approval in the country. Can you talk to us a little bit more about how it was to get around that red tape? I mean, surely you were just in a position where you're just arguing with the country to advocate for your patient. Was there ever a time where you didn't think it was going to get accepted? So
I'm going to be honest. I mean, my job is very busy, as I know a lot of people have very busy jobs. My job is very busy, and in order to do this, I spent many hours on top of my already busy job, so on the weekend and in the evenings, to try to sort this out. We thankfully had the support of other team members as well, but basically there were many letters written. I needed to find someone who was going to help us to kind of provide this system to us and help us to learn how to use it and help us to insert it. And so I started with communication with an expert in France, and then contacted the Roche. And eventually over time, I got connected with this amazing woman, so Beata, from Roche, who said, this needs to happen. This child's life depends on it. And she pushed things through Roche in order to get them to not only provide us with a system, but also to bring a surgeon to us from Germany to help our surgical team to learn how to insert the system, and then to train me and Edgar Bélanger, the diabetes nurse and a certified diabetes educator who looks after Sacha, on how to use the system. But it wasn't very straightforward, because the government came back and said, no, and we need this and we need that, and have you exhausted all your options? What options have you exhausted? What about an islet cell transplant? So there was kind of many back and forths. And finally, we got approval from Health Canada. We got the some support with the funding, so a lot of support with funding from Roche. I had originally tried to get funding through the government and I was denied, unfortunately. And then once that was all put together, we thought we were good to go. And poor Sacha was in hospital, and we're like, we have the device coming, we have the surgeon. And then we had COVID. And the surgeon wasn't allowed into the country. And so we had gone through kind of the process of getting all kinds of exemptions, writing lots of letters. I had to get permission from CHEO, but then we needed to get permission from Canada to bring him into the country. And we thought it was done. And then he called me from the airport and he said, I'm stuck here. They won't let me on the plane because I don't have a letter. He had letters from me and letters from CHEO, but not a letter from the government saying that he could come in. So there he was. Yeah. And so Sunday morning, I was on the phone with Border Services Canada and with the COVID people from Health Canada saying, this can't happen. This child's life depends on it. And they were really trying to help us, didn't know what to do. I called Air Canada and the lady there was lovely. And she's like, let me try to call Lufthansa and convince him to let him on the plane. They sent him back home. He slept there overnight. We had more conversations. And eventually they were like, okay, you can get on the plane. And he came and he did it. He's a lovely, lovely man. And he trained our surgeon. But it was, you wouldn't believe how much red tape there was. But we got there, and thankfully we have a great team of people who all worked together to make this happen for Sacha. Like, it wasn't me doing it alone. I had lots of other people doing it with me, which was great. Yeah.
Yeah, just such an ordeal. It's almost insane to think that such a rare case and such a thing where there's only one possible solution, and then there's all this red tape, all these complications added on top, and then never mind have it happen to her in the middle of a pandemic where there's even more travel restrictions up all over the place. Just to clarify a couple of them, Roche, that you mentioned a few times, the Swiss company that make the apparatus and the device that Sacha is now using, and this treatment method in particular, the way that she is now receiving her insulin, how does that differ from all the other alternatives that you tried? You mentioned combining insulin with a couple of things, but the issue was with the fatty layer just below the skin. So how does this product bypass that?
Yeah. So the other treatments that we tried were to give different types of insulin or to give medications that stop inflammation. All of those medications actually have side effects to them. But what this does is her reaction is at the level of her fatty layer just beneath the skin. And with insulin injections, where you're injecting into the fatty layer, with insulin pumps, which is kind of a continuous method of insulin delivery that also delivers insulin to just beneath the fatty layer. We had tried something called an insulin desensitization, where we gave her very, very small amounts of insulin with the help of our allergist, and gradually built them up, because in some people with an allergy that will stop the allergy, but that didn't work. And so what this system does, it's called the Diaport system. It takes, there's a little catheter that goes through the skin and the abdomen, through the fatty layer in the abdomen, and it goes into the intraperitoneal cavity. So that's kind of the fluid-filled cavity inside of your abdomen, and it delivers insulin directly in there. So it doesn't, the insulin, that the tubing goes through the fatty layer, but the insulin doesn't touch that fatty layer. And because Sacha's reaction is within her fatty layer, it prevents her from having any reaction at all.
It's saying that the insulin that's going straight into her cavity is a different kind of insulin to the ones you would maybe put straight into yourself?
So it's different from the ones that are available in Canada. It was tested compared to many of the insulins that are available in Canada. And what they found was this one particular insulin had a structure, like a molecular structure, that prevented it from being degraded. So it prevented it from being broken down in the intraperitoneal cavity, whereas the other insulins that are used like for subcutaneous injections, so the regular insulins that we use here in Canada, would be broken down in the intraperitoneal cavity. They're not as kind of robust in that area.
Okay, so that's the difference there. I would like Dr. Ahmet. I want to move on to speak a little bit about Dr. Klaus Keeling. You mentioned the German surgeon who came over. How was, first of all, before we dive into who he is? I mean, how was this all funded? I mean, if there's so much red tape to come through, was it CHEO who had to fund it? How did the surgeon come over here and all this? How was that put together?
So that was one of the biggest challenges initially, was how was this going to be funded? It was an expensive device. The consumables, so the parts that need to be changed on a regular basis, are very expensive. And then we needed to be trained. But it was Roche that funded it. So Roche Canada funded it in part, and Roche Global funded the surgeon to come over. And we were just very fortunate to have partnered with the people at Roche who really understood that this was, an individual that needed help. And so they paid for Dr. Klaus's travel and lodging here in Canada.
That's an absolutely fantastic success story there, to have a company step forward and really be able to aid this one young girl who really needed that. You mentioned earlier as well, so Dr. Keeling came over. I take it wasn't just he comes in, does the surgery and leaves. It was a bit of an educational process as well, talking about this different kind of system.
Yeah, so he actually didn't do the surgery itself, because in Canada, in order to perform a surgery, you need to be certified in Canada as a surgeon. And so the way what he did was he actually met ahead of time with Dr. Kyle Cowan. So he's a general surgeon at CHEO, who agreed to performing this new surgery, first time in Canada surgery. And he had spoken to him on a Zoom call beforehand, and then he came in. They spent some time with education around how the surgery would proceed. And then he was available to Dr. Cowan in the OR in case there were any questions, for example. And he also saw Sacha. He helped to determine where this device would be inserted. And so he was involved in the process, but didn't actually do the surgery itself.
And in terms of, the surgery has been and done now. I'm sure you've seen Sacha since. How is she doing? How is the treatment working?
Yeah, so she's doing great. Her blood sugars, even right after it went in, it was the first time we saw her blood sugars when she had been off of IV insulin come into or close to our target range. So that was just so wonderful to see. It is a surgery, so there's a process of recovery for Sacha, but I hear that things are starting to go back to a little bit more close to normal for her, which is really nice. She made it to her prom, which was our big goal, and Roche understood that, and Dr. Klaus understood that, and so we were so happy to get that going and to allow her to get there. But I understand that she's doing quite well. I had an email communication with Mom yesterday, actually, and I think that she's doing very well. Yeah.
That's
and I said Dr. Klaus,
fun.
but sorry, I didn't mean to interrupt. I said Dr. Klaus, but it's Dr. Keeling. It's Klaus Keeling. I said his name wrong, but it's Dr. Keeling. Yeah.
Trust me, around the office he's been referred to as Dr. Klaus as well, because it's just a very emphatic name. But yes, indeed, it is Dr. Klaus Keeling. So, Dr. Ahmet, before I let you go, what's the next steps from here? You mentioned earlier on in the interview about potential alternative treatments that you're hoping that they actually move forward with technology as time moves forward as well, so they become more viable options for Sacha. But what's the process now? Is it just a hope this treatment works, and also because it's not approved here, it's not being funded either, so there's having to find alternative ways. So what's the process for you now? Is it trying to get this approved? What's the next steps?
Yeah. Sure. So we do have approval for Sacha to use this long-term in Canada. So it's for Sacha alone and not for, if another individual needed this device, they'd need to go through the same process. As you mentioned, the challenge is the cost. Roche paid for the cost of all the consumables for the first year up front, but moving forward, we're going to need a solution to that. We did get agreement from the Assisted Devices Program in Ontario for them to fund part of that, but only the portion that they would be giving towards insulin pump supplies. And insulin pump supplies are a lot less expensive because they're less complex. We had set up a GoFundMe page with Sacha and her mom, and we're hopeful that people will donate to that because that will really help with the cost of these consumables over time. The other kind of roadblock that we've run into is there was talk about discontinuing the type of insulin that she's using in 2022. That wouldn't only affect Sacha, but it would affect the other kind of 70 plus people across the world who are using the Diaport system. And so we've been working with Roche and the company that makes the insulin to see if we could find a solution to this. I understand from the contact that I have at Roche that may be moving forward. So I'm very hopeful that the insulin will be available long term, but we're waiting on that. And so for Sacha, if that insulin does remain available long term, this could be a long term solution for her. And I think it would be a good long term solution. So not that different from using an insulin pump, for example. But as she gets older and as diabetes research progresses, I'm very hopeful that there is that islet cell transplants become more mainstream, less side effects, last longer, and that in the future, that's going to be a solution for her and hopefully for other people with type 1 diabetes, even if they don't have the insulin allergies.
All right, Dr. Ahmet, thank you so much for this absolutely riveting conversation today. It's been great to dive into this world. And also, we've spoken to so many people who have put so much credit towards, of course, the team as well, but the work you've done and the way you've advocated for Sacha Cardinal here in the region as well. So I can tell you a big thank you from all the communities for the work you've done. And thank you so much for coming on today. Hopefully, we've enlightened some people about this very rare, bizarre case, a first in Canada surgery that you guys were involved with, and I really do hope that everything moves forward and we can catch up again in the future with some very positive news.
Well, thank you very much, and thank you for welcoming me to your show.
Cheers. And thank you very much for watching, everyone. We'll be back soon with another episode of Insight of TVC 22. See you soon. Goodbye.